The next speaker we have is Dr. Daniel Kalla. Dan has been a staff emergency physician at St. Paul's and Mount St. Joseph's Hospital since 1998. He's been the emergency department chair and co-program director of acute care services for PHC since 2013. He's a clinical associate professor at the University of British Columbia. He is the author of 10 published novels which have been translated into 12 languages. And he's probably one of the most productive people I've ever met, so pretty excited to have him back. He always does a great talk of M&M cases, and he's back by popular demand for another round at M&M cases from the St. Paul's Hospital ED. Thanks, Dan.
Thanks, Rob. Am I live, Paul? Great. Thanks, Rob. It's good to be back. So starting with the disclosures, I have no financial conflicts, no pharmaceutical funding. I'm still open to both. And these cases are not mine. I can't stress enough, I've got enough crime scenes, medical crime scenes with my fingerprints all over them, and these are not mine, but they are, I think I've really plagiarized some great cases this year. My colleagues have all come through. I always put out a call for new cases, and I actually get, and most of them are actually sad cases. But I think there's something interesting to learn from all of them. So today I want to provide a few useful pearls for you. I want to warn you of a few pitfalls, but perhaps most importantly, I want to improve my speaker evaluations. I've given this talk several times, and suffice it to say there's a little wiggle room in my previous evaluations for improvement. They haven't always been stellar. For example, I'm going to give you a few examples to illustrate my point and to show how words can hurt people. In 2016, somebody said, Kalla has all the medical expertise of a Gwyneth Paltrow and the scientific credibility of a Jenny McCarthy. In 2018, somebody said, Kalla's talk would be much better if someone else gave it, and didn't use his slides. So this is a recent unfortunate case at St. Paul's. It does leave us with a bit of egg on our faces, but it raises some important communication and systemic issues, so I wanted to talk about it. It's a 41-year-old male who was triaged at level 2, shortness of breath and general weakness, kind of soft blood pressure, not really shocky, not great, O2 sat 97%, GCS 15, past history of polysubstance abuse. At St. Paul's, we call these patients next in line because we see a lot of them. And I think I have a photo somewhere. I thought this was a meth binge, maybe not. Buffalo Bill complication there. So the EP saw the patient at 7:16, diagnosed possible pneumosepsis, ordered labs, fluids, Peptazo. It was a very difficult IV access, but eventually the nurses, who were brilliant at St. Paul's at getting IVs, got a 22 gauge in at 8:04. The chest x-ray came back, confirmed a lot of patchy infiltrate and consistent with pneumonia. The problem is the IV went interstitial at 8:40 after less than a liter of fluid. There were 6 failed IV attempts by 3 nurses over the next while. Blood work couldn't be drawn. The RN called the EP twice, at least, maybe more, but 2 times documented the chart. The EP was tied up with another critical patient. He asked them just to please keep trying. IV therapy team came down at 8:55, still no luck with the IV. At 9:35, this guy started to take a turn south in a hurry. His blood pressure dropped to 78/55, his heart rate went up, he started to desat. By 10 o'clock, they did establish a central IJ line, and at this point, labs were taken and fluids given, ICU consulted, the antibiotics were started. So the initial labs tests were quite horrific. The white count of 25.6, a CRP of 305, he was anemic, his trope was 127, his BNP was greater than 7,000, his lactate was over 16. You know, and probably we see a lot of infective endocarditis, and with a kind of heart failure and a cardiac involvement, there's a good chance that's what he had. When you look at his initial labs, they weren't drawn until 10:17. The guy had presented before 7 in the morning. And unfortunately, at 11:47, he went into a PA arrest. He was intubated, epi was given, bicarb, calcium. He had a return of spontaneous circulation after 3 rounds at 11:56. But unfortunately, he had another arrest at 12:23. The code was run for 26 minutes. His lactate went from 16 to 23. I don't know about you, maybe I'm paranoid, but if a lactate creeps up over 20, I start getting a bit concerned. And they ran the epi, they did everything, and he was declared dead at 12:49. But it's worth considering. This was a 41-year-old. He was a substance abuser, but he was otherwise a relatively healthy guy, and he died of sepsis 6 hours after presenting to us. What could we have done differently, maybe? So we all know that sepsis is a time-critical condition, right? And this is from the 2019 Sepsis Surviving Sepsis Guidelines. And we know we have that first golden hour where we have all the targets. You want to do in the first hour, you want to at least measure the lactate level, get blood cultures, start antibiotics, and get some fluid into them. If you look at the times on our chart, this really wasn't met at all. And in fact, if you go back and plug these times in, we clearly flailed this patient with the time that he got everything. And so, yeah. Did I mention I wasn't involved in this patient's care at some point? But everything's obvious in retrospect, you know? And we see tons of, I wasn't joking, we see tons of these patients, right? We see so many patients who present with soft blood pressure, IVDUs, you know, sometimes their O2 is a little bit low. A lot of them are septic, a lot of them are terrible IV starts, a lot of them don't get on antibiotic for hours, most of them do fine. To tease this one patient out of the weeds isn't really fair because it's a huge number that we're talking about. But maybe we could have done some stuff differently this time around, and it's worth learning from this case. So what might have been done differently? Intraosseous is your friend, right? It's been so well established that you can use IO for any medication or fluid you want in adults. CGEM confirmed this in 2015 when they said it's perfectly safe to use pressors through an IO line. So we could have given him fluids and pressors if he needed pressors that way. And what about blood work? Well, you can use intraosseous for blood work as well. There's good correlation between hemoglobin and lactate and pH, all the key things we need in an early septic workup. So think about IO when you're really struggling. It's not that cruel a thing to do. And if you've got to use it, like one of the speakers mentioned yesterday, put a cc of freezing in, and that really helps decrease the pain in the marrow. What about steroids? You know, funnily enough, when I put this PowerPoint talk together, as soon as I typed steroids, PowerPoint suggested a clip art photo. And I don't know. Actually, Rob, I'm kidding, but Rob's a Western Canadian CrossFit champion. The man's a superhero. Like, it's just incredible what he does. I've still never seen a urine sample from him, but that's neither here nor there. So what about steroids in pneumonia and pneumosepsis? Cochrane did an interesting study review in 2017 with a lot of studies and almost 2,300 patients. And they looked at people with severe pneumonia and looked at the outcome with and without steroids. And it was actually quite interesting. The steroid group had lower mortality, shorter time to cure, and fewer complications. They had a higher rate of hyperglycemia, but it wasn't clinically significant. And you only needed to treat 18 patients to prevent one death in this study, in this review. So the strength of evidence was listed as moderate, but it's actually changed my practice. I now give steroids. And there's even suggestion for less sick patients that steroid will accelerate their recovery time. Okay, I wanted to point out another quote from 2017 about me. Kalla owes me 2 Zantacs and 25 minutes of my life that he stole. Case 2. 67-year-old male. He presented at 14:20 in the afternoon. I want you to remember the times because the man had woken at 7:30 with left arm weakness, numbness, and a limp left hand. He had no grip. And he thought, I'll just wait it out. And, you know, I love those old-fashioned stoic guys we see in the emergency department, the kind who don't get bent out of shape at all by a little thing like a touch of dense hemiplegia. And, and he walked in, you know, with a limp, 7 or 8 hours after his stroke, and his history is full of hypertension and all the risk factors, and he's on a whole bunch of meds. His vital signs aren't too bad. His left arm is really weak. He can barely lift it. Can't really lift it against gravity. His LAMB score, if you use that, is quite high at 4 out of 5. Normal sinus rhythm. And if you look at his CT, there's evidence of early ischemic change in his parietemporal lobe there. And if you look at his CTA, you can see an obvious occlusion of the proximal MCA there on the right side. So this guy presents 7 hours after his CVA with proximal right MCA occlusion and a profound deficit in his left arm. You call the neurologist and they say, sorry, it's too late for TPA. And you go, thanks, and you know. But the person, luckily, the EP didn't stop there. He called interventional radiology and the stroke neurologist at VGH. And they accepted the patient for thrombectomy. And actually, the patient had a great functional outcome after thrombectomy. And yeah, he subsequently cut off his left thumb, but he didn't seek medical attention for that. So what is thrombectomy? It's the mechanical removal of thrombus embolus from large intracerebral vessels using fluoroscopy and a wire. They use the access via the femoral route, and it's only for large vessel ischemic strokes. So who is a definite candidate for it? There's a pre-stroke scoring scale that I'm going to get into, MRS, in a second, but you want the acute ischemic CVAs who have had TPA, you want them to have TPA, and a proximal occlusion. Ideally, you want to get them onto the radiology table in under 6 hours, and you want the people who are going to go on to have potentially disabling deficits, and it overall only applies to about 10% of strokes. So what is the MRS score? It's a modified Rankin scoring system. You know, the neurologists use the NIH-SS score when they're assessing strokes, which is like an 11-point score based on a physical exam findings. I don't know about you, but I haven't checked more than 5 things on a physical exam since 1997. So I don't know how to do that score. Well, don't tell MSP. They think I do social histories on everybody. But basically, if you look at it in a very simplified way, you're aiming for the high-functioning guy up here. This is moderate disability, and this is not so happy and existent down there, and 6 is dead. So how good is thrombectomy? Well, Lancet reviewed in 2017 about 1,300 cases, and their primary outcome was this guy, to get functional score. And it was a pretty impressive study. Of the treated group, 46% got back to this group versus 27% of the non-treated group. And you only needed to treat 2 to 6 for functional outcome. So the number needed to treat is also very impressive on that. 90% of the people also received TPA in this study, and there was no increased rate of intracranial hemorrhage in the study. So what about delayed presentation like our guys? Well, it's a little less clear if the benefit's there, but there's likely benefit. There was a big trial called the DAWN trial that did it up to 24 hours, and what they found is if there was a clinical infarct mismatch, in other words, a lot of strokes are stuttering, so if the CT looked better than it should at a certain hour, then they had really good outcomes. And at VGH, they'll do thrombectomy up to 16 hours post-CVA. So just to highlight the key points there, it's only for proximal occlusion, it's only for a minority of strokes, and you still give TPA. Earlier is better, but consider it. And if in doubt, consult a stroke neurologist. Literally, they're the only people in the world who are happy to hear about weak and dizzy patients. So, I know you guys are tired of this, but I'm going to keep going. I've got my 2000 evaluation. And this one I got to say was fair because. So, case 3, 73-year-old male presents to a small coastal ED, sudden left shoulder and chest pain that resolved in the ED. Troponin over the next 12 hours kind of gradually creeps up. Non-specific changes on her ST, on her ECG. Chest X-ray, mildly enlarged heart, but nothing to hang your hat on. And she was treated very appropriately as a non-STEMI. In hospital, her pain was intermittent, but then she was given metoprolol for this persistent tachycardia, and she just crumped at that point, her decreased LOC and hypotension. She was intubated, they had to start her on pressors, and they referred her through PTN to St. Paul's ICU. And so ICU typical situation was full, and of course we weren't notified. I do some work with the ambulance, and PTN does an amazing job of arranging transfers, but I'm not sure about you guys, But so often at St. Paul's, when a consultant accepts a patient without notifying ED, I mean, they arrive, it's about as welcome as a surprise case of genital herpes, right? We're not prepared. And this is what happened in this case. It was a gong show when the patient arrived, because she was very, very sick. She was on a norepinephrine with 2 central lines. And the clever emergency doctor who saw her decided it was best to have a look at her heart with bedside ultrasound. I'm not as slick as many of our group with ultrasound, but I can clearly see the uterus is empty on here. Actually, if you look at this video, there you can see the flap right here that's the aortic root, and there's the flap of the dissection. And on the CT that was very soon done, you see it's a type A dissection with blood around the heart, and it tracks all the way down to the iliac arteries. And you can see the flap again right here on the CT. So it's a big dissection, and it was also, they've got a transesophageal echo, and they found there's pericardial fluid with an organized thrombus, and her RA and RV were being compressed. So she was very sick. Unfortunately, she was taken to the OR, and she died on the table. But it raises some interesting points about aortic dissection that I think are worth talking about. It can be a difficult diagnosis, right? And missed aortic dissections are a common source of medical legal complaints. Even my very close friends at CMPA say this about it. The diagnosis may elude the most experienced clinicians. Missing the diagnosis does not necessarily represent negligent care. And the problem is it's not that common, right? 6 out of 100,000 per year, male higher than female, complicated pathology. And at St. Paul's and many of the urban sites, we're spoiled with easy access. I know many of you don't have that easy access to CT. So the question is, can you rule out an aortic dissection without a CT scan or an echo? I mean, we've been talking, since Julian was in med school with William Osler, we've been talking about this whole bilateral blood pressure stuff. And the pulse deficit, is there really anything to it? Well, there's something to it, for sure. You're way more likely to have a dissection in terms of if you have a bilateral, if you have a pulse deficit or blood pressure deficit. But the problem is, it's nonspecific and not very sensitive, and tons of healthy people, up to 20%, have a big deficit anyway. So I wouldn't hang your hat on that at all. It'd be worth doing, but I'd call that a fail. What about an aortic dissection score? This came out in circulation in 2011. What about an ADD, they call it, aortic dissection score? And how they make this score is they look at patients who are high risk for dissection with chest pain, abdo pain, syncope, and they categorize the 3 different groups of high risk conditions. So it starts with, do they have a history that's compatible? Marfan's, connective tissue disease, family history, known aortic manipulation. High risk pain features, do they have abrupt onset? Do they have severe intensity, ripping or tearing? And finally, do they have high risk features? Do they have a loud murmur of a new aortic murmur of aortic insufficiency? Do they have hypotension or shock? But the problem is when they look at all these factors through thousands of patients, they found even the ones who scored 0, who had none of those factors, still have a 4.3% rate of having the conditions. So this led this group of obnoxious cardiologists to say, do not use any clinical decision rules alone. And what about a negative D-dimer? D-dimers will be negative in 2 to 3% of all cases of people with aortic dissections, right? So the same group of, So the same group of assholes are back with this recommendation. Don't hang your hat on D-dimers. So what if we combine the two? What if we combine D-dimer with the ADD score? I don't really have time to explain likelihood ratio normograms. Actually, I do. I don't understand them, but they're kind of interesting. If you do this ADD if you take the lowest risk group with ADD of 0, and you know their pre-test probability is 4.3%. So you plug that in here, and you know that if they have a negative D-dimer, there's like only a 2 to 3% risk of them having a dissection. And then you draw the line and you get the post-test probability. And it means that if they're low risk and their D-dimer is negative, their test probability is 0.2% or 1 in 500 of having a dissection. And even if you do the same with the group who has a significant risk, say they had Marfan's, or say they have family history, or say they have a strong pulse deficit, and they have a 26% incident, a pretest incidence, you still plug it in, and it reduces their post-test probability to 1%, right? And they validated this in a study that came out, it was called the ADVISE study. They looked at 850 patients, it just came out last year, of which a quarter of them had aortic dissection. So these were high-risk people. But only 8 of the negative D-dimer group had dissection. And if you put the AD score less than 2 and the D-dimer negative, only 3 out of 924, so 0.3% had dissections. So what does it mean for us? Well, in my opinion, and this is not legally binding, low risk for ADD and negative dimer probably doesn't need imaging. I mean, roll the dice once that. Because if you're wrong, it's not like you're going to die. And it's logic like that probably led to this comment in 2005. Last case, and I think this is a doozy, and we're right on time to do it. 21-year-old previously healthy male, no past history, no medications. He had immunization up to date, no recent travel, no infectious contact. He lived in Nanaimo. This case started in Nanaimo, a shout out to the Nanaimo group, but ended up at St. Paul's. He presented to Nanaimo on July 5th. He had 1 week of isolated numbness to his left thumb that went on to the left arm. Soon it went to his right arm. Then when he presented, he had weakness in the left arm. He had meningismus, he had difficulty swallowing, and he had visited a chiropractor on July 5th who advised to go to the ER. My notes say insert chiropractor joke here, but I think that would be manipulative. The vitals weren't that bad. He was a little bit hypertensive, a little tachy. He had some tenderness to his neck. He had a bit of weakness to his arm. The swallowing was noted to be normal. He went on to have an MRI in Nanaimo, which showed cord edema, and he was started on empiric ceftriaxone. That night, he got really sick. He became what looked like sepsis at the time, tachycardic, and his O2 dropped, even though his chest x-ray was clear. He had to be intubated for respiratory failure and admitted to the ICU. And when you look at his blood work that came back, it's really not very impressive. Normal white count, normal CRP. White count, his LP only had 12 white cells in it, and they were mainly lymphocytes. His MRI had a bunch of changes in both his T-spine, his cervical spine, and he went on to develop a bit of aspiration pneumonia and was put on antibiotics. Their working diagnosis was acute disseminated encephalomyelitis, ADEM, or plus or minus transverse myelitis. He was transferred to St. Paul's because they wanted to get plasma exchange pheresis, PLEX, and pulse steroids under the supervision of the neurologists. So neurology consult, if you read their consult, yada, 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 18 pages later says the same thing. He was up here. And he had his first run of PLEX IV methylprednisolone. Then ID got involved, and you can imagine they tested him for just about everything under the sun, and everything was negative. He didn't have lupus, didn't have any inflammatory disease. His cultures were negative. All these viruses, syphilis was negative, everything. But the radiologist, when they re-MRI'd him, noted that the pattern was unusual for myelitis and ADEM. He got worse. July 10th, his pupils fixed. He lost all his deep tendon reflexes, no gag, no posturing, not triggering the ventilator, and they tried some Hail Mary medication. Somebody was smart enough to go back and question them about the social history, which they'd taken before. He swore there was no travel. But they found out that the son was kayaking near the father remembers the son had been kayaking near Port Alberni, and a bat came down and scratched him in the wedge face of the left thumb. And that was the aha moment. Of course, it was too late for him. They did send all kinds of cultures off for rabies. The next day, his EEG just showed global suppression. They met with all the consultants in the family. They withdrew care, and rabies was confirmed post-mortem on this patient. So just a quick my last 2 minutes, I'm just going to spend on rabies. It's a worldwide distribution. There's less than 30 cases in Canada in the past 100 years. Transmission is always via saliva or a scratch, where there's saliva on the paw. In the developing world, most of it is related to rabid dogs, but in BC, only bats are a reservoir for rabies. And CDC estimates about 1% of bats in BC carry rabies, but bats who have rabies will be more aggressive, right? You don't want an aggressive bat. Incubation period is typically 1 to 3 months, but variable. So you have to get that treatment in within a month, the immunization. It's 100% fatal, basically. There's only been one survivor in all of North America and 26 worldwide. There's two types of clinical presentation. There's the furious rabies, which is what the one people know. It's the irritation, the psychosis, the progressive neurologic symptom, the seizures. It's the hydrophobia, which there's a long explanation here for we don't have time for, and that leads to multi-organ failure and death. And then there's the paralytic rabies, which is like a very severe case of Guillain-Barré syndrome. And the diagnosis is clinical plus sending specific markers. CSF doesn't really help you unless you send it off for PCR for rabies. Probably the most sensitive test is the rabies antigen detected on skin biopsy through DFA testing. So where are the rabies reservoirs? Well, in BC, as I said, there's only bats, but in the rest of Canada, in the north, foxes carry rabies, and in the east, the far east, the Maritimes, raccoons carry rabies. So if you look at the geographic distribution, the foxes are up here, the raccoon cases here. I have no idea what's down here, but but let's not get too excited about diagnosing rabies. There's one case in BC in the last 15 years. So next time you see someone you think has hydrophobia and frank psychosis, it's much more likely it was just somebody who is out at Buffalo Bill. So who needs rabies prophylaxis? Just really quickly. Anybody who's been in contact with the saliva of neurofluid. The risk to healthcare transmission, the reason this came up so much for the emergency is all the ICU staff was coming down for rabies post-exposure prophylaxis. Most of them didn't need it, but we gave it to them anyway. And if you're in doubt, call the public health officer. They're so helpful. It's really this group. Any exposure to bats, if there's a suspected bite or scratch, absolutely have to get rabies prophylaxis. If there's a wild domestic animal that's behaving bizarrely, I guess that's relatively high risk as well. But you only have one shot to do this. This isn't, there is no survival if they don't get immunized. And how you give rabies, I don't know if everybody's ever given rabies prophylaxis, but you give the immune globulin into the site of the wound at a dose that's prescribed here, and then they go on a 4-day series where they get the rabies vaccine. Okay. So just quickly, my take-home points today are sepsis need urgent parenteral access and IO is adequate. Consider thrombectomy for very select CVAs, but don't delay TPA. Negative D-dimer and low ADD score is extremely low risk for aortic dissection. And MBC rabies comes from bats. And to end on a happier note, from my 2017 evaluation, I was a little proud of this one. It was a bit dull and not very informative, but overall you did fine, dear. That was the year my mom came to the conference. Thank you.